And the speaker of today, Dr. Pooja Sinha, is a senior vitreoretinal consultant at AB Eye Institute Patna. She did her vitreoretinal fellowship from Shankar Nethralaya, Chennai. Earlier, she was attached with vitreoretinal department of Stanford University, USA, and Oxford Radcliffe Hospital, Hull Royal Infirmary, UK. She served as chief instructor for instruction course on indirect ophthalmoscopy at AIS, DOS, and SARC meets. Awarded with Dr. D.K. Bose Gold Medal for Best Paper Presentation and Appreciation Award for the work from national and international society like UNICEF. Dr. Pooja Sinha is one of the moderators of today's program, and she is also the eminent speaker of today's program. Now, may I request
Fine.
Am I audible?
Yes.
Okay, so very good evening to all the postgraduates over here attending today's evening's webinar. Today we'll be speaking on indirect ophthalmoscopy. This is indirect ophthalmoscopy, believe me, is a very versatile and useful optical tool to view the retina, especially the peripheral retina, with the added bonus of stereopsis. So as we go along, I'll explain everything possible in 1 hour. I have a lot of slides and we will welcome any questions subsequently. The motive of this talk today is not to make you very versatile and experts in doing indirect ophthalmoscopy. I know it's not possible in one evening. This is just to incite interest and also to know the theoretical part so that you can then gear up with your indirect ophthalmoscope, go to the OPD and keep practicing till you become perfect. So now let's go on to the first talk, the first slide. Indirect ophthalmoscope was introduced by Nejon in 1864. Indirect ophthalmoscopy involves making the eye highly myopic by placing a high power convex lens in front of the eye so that a real, inverted, and laterally reversed image is formed close to the principal focus of the lens between the lens and the observer. Indirect ophthalmoscope, as we know now, the binocular head-mounted indirect ophthalmoscope was introduced by Charles Keepens in 1951, and this is more or less how it stands today. The technique is called indirect because the fundus is seen through a condensing lens. Now, we all should know about this Gulf-Strands principle, which is the basis of indirect ophthalmoscope. The illuminating and the viewing beams must be totally separated through the cornea, pupillary aperture, and the lens to avoid reflections, but must coincide onto the retina to permit viewing. So you see three the three beams. The top one, the yellow one, is the illuminating beam, and the two bottom, the pinkish red ones, are the viewing beams. So all these three beams have to pass through the pupillary aperture. So that is why the pupils have to be properly dilated, and only when these three beams pass through the pupil will you get a good stereopsis and a good view of the retina. So binocularity is achieved by reducing the observer's interpupillary distance from about 60 millimeters to approximately 15 millimeters by prisms or mirrors. So you can see these rays of light which then fall on these prisms, and then the interpupillary distance is increased to 60 millimeters before they enter the observer's eye. This is another diagram to illustrate what I have told you about. The examiner's eyes being further apart than the two viewing. Yes, sir.
I'm sorry, I had to stop you in between. Can we go back to the previous slide, please?
Yes.
For the postgraduates, I know this is a DNB question. They have asked us a short question once in a while. This optical system of indirect ophthalmoscopy. Go back one slide, please.
Another one?
Yeah. This is the one. Yeah. That's it. So I know this is we being biology more based people, we being more medical people, physics, rays of light, convergence, divergence through lenses are not our cup of tea. But as ophthalmology postgraduates, this is expected of you. You will get this asked once in a while, even in spotters, even during Viva. Sometimes you will just be given the 20D lens and told what kind of a lens is this. They do deviate to what are the intraocular lenses. Sometimes they can ask you what is the 20 diopter lens, how does one use it, what is the principle behind it. So you should know this name and the drawing that Dr. Pooja has shown over here. The next slide, please.
Okay, sir. Can I go ahead?
Yeah. So this slide also, yeah, these ones for the postgraduates, I think you have to learn these up, because if you get a question on this, you are expected to show some of these drawings over there. Dr. Pooja, thank you so much. Please continue.
Okay, thank you. So now we go on to the parts of the indirect ophthalmoscope. Basically, you have two main parts. You have the top knob, you have the vertical band, the horizontal band, and then you have the front head mount, which houses the optical system and the illumination system. So I know that all postgraduates and all of us in the beginning are very, very excited to view what is there in the retina and what are the structures that we are going to see. But the picture that I have shown you here is just to make you, just to tell you that wearing the indirect ophthalmoscope has to be also done in a manner so that it is comfortable for you. It has to fit snugly on your head, not too tight, not too loose, because if you are in a hurry and if the instrument is not mounted properly, you will not give too much time to view the structures. Okay, so patience is required, and you have to tighten the top knob and the back knob in such a way that the instrument fits snugly. Now going on to the rheostat. This is in some battery mounted indirects. Now it is there on the head itself, head mount, and otherwise you can have a battery system also, which I will be showing in my next slide. This is the battery system. Now the rheostat helps us to determine the intensity of illumination. Always remember that the intensity of illumination has to be medium. It has to be moderate. If you make it too much to the right, a very intense illumination, the patient will be very uncomfortable, and then you both will be in a hurry to finish off the examination. Now, what is this lever, the bottom lever? This lever can be moved to converge the illumination and the viewing beams. As I told you, this Gulfstran's principle, you can see these three beams. Can you see it on the screen? This can be moved to converge them so that these three beams then pass to the pupil and the stereopsis can be obtained, even in small pupils. Sometimes the pupil doesn't dilate properly. It is only 2 millimeters. So then you use this lever to approximate these three beams so that then again they pass through the pupil. This is the adjustment knob on the top right hand side, where the height and the angulation of the optics can be adjusted. Okay, everyone is following me? Now we come to the adjustment of the interpupillary diameter, which could be variable. It could be 60 mm for some, 65 for some people. So you just adjust the interpupillary diameter. This is the bottom lever to these push buttons to adjust the IPDs, just like you have in microscopes. Now there are two knobs here on the sides. This is for the filter knob, and you have 4 different colors here. You have the red free or the green, the yellow filter, and the blue filter. Okay, so you can adjust them depending on what filter you want to use. Now, any of the graduates want to know what are these 3 filters and what are they used for?
No, why don't we, am I audible to Sinha here? Am I
yes,
audible?
sir?
Yeah, I had got logged out. I had got logged out. Why don't we ask, yesterday we had a very interesting thing. Why don't we ask the audience that those of you who know in the message box, why don't you inbox us regarding the red, blue, these filters, what they are used for, what lesions. We'll come back to this later on, Pooja, if it's okay with you.
Yes, sir, it's okay with me. So we, if people have doubts, I can always answer your question. So these are the filters. And now there's another knob here. What does it show? It shows the different spot sizes. You have the small spot size, a little bigger, maximum spot size, and then you have the diffuser spot size. Okay, so the spot size is also useful in determining what is the size of the illumination that you want to focus on the patient's eye. The diffuser spot size, one we must all know, they can ask you in the exam what is the meaning of that. This is basically for learners so that a diffuse soft beam of light can be focused onto the pupil. So now we come to a very important part, that is the centering. How do we do the centering? The centering has to be done against the thumb of the outstretched hand. Okay, like I am showing in this picture.
Dr. Pooja, can I speak in between?
Yes, please. Yes, please.
Yeah.
Please go on.
For the procedures, what Dr. Pooja is showing is absolutely fine by me. Uh, I also, for those who are just starting the radiotherapy, what I do ask them is, once you've adjusted the headband, the upper part of your thing, you're trying to throw the IPD, you've slid the inferior ones, and then look at the wall. I always ask everybody, look at the wall, close your right eye, close your left eye. You will see the moving here and there. Open both your eyes, see if it's centered, see if you see with both eyes kept. At the same time, the same spots on the wall. Walk away a little bit. It should become smaller initially, smaller, more larger as you walk away and close to the wall. And also at the same time, exactly what Dr. Pooja is doing. Put your thumb up, right up to where you're in front of your, far away from you, up to your eye level, and look at the wall. And make sure that the thumb is, when you close the right eye and left eye alternately, you can see the thumb centered over there. It shouldn't be moving too much over there. Then you know that both your IPD sizes are fine and the image on the wall is fine, and you will be able to see a patient properly. Just jamming on the internet onto your head, immediately taking the lens is not a great idea. It's we have a question here. Shogoto's question. I have one question in one slide. You told IPD reduced by 50 to 50 millimeters. No, I don't think. I think maybe a C more. 1 minute. By using no. IPD has the interpupillary distance has to be adjusted, Dr. Shoigoto. I can understand there was a maybe something that we didn't go get the message didn't go correctly. The by what Dr. Pooja means is your own IPD, like when you operate, you know what the IPD is. Like when you do prescribe glasses, you know what the IPD the patient is. That is the IPD that she's referring to. You should know that. In the microscope, it's written what the IPD, the millimeters written over there. In the endoscope, most of it is not written. So you have to adjust it yourself manually, and which is correct for you. That's what she means. Shall we go ahead, Dr. Pooja, please?
Yes, I will go ahead. So this is a very important Dr. Saurabh has given about the centering. So now we come to the actual examination. Okay, the room has to be darkened. This is very important. The patient's pupil has to be fully dilated, and the examiner has to be partially dark adapted. Now, how do we do the indirect ophthalmoscopy? Many postgraduates ask me, ma'am, is it okay to be doing it when the patient is supine or the patient is sitting down? Believe me, till this date, I always do indirect ophthalmoscopy when the patient is lying down. I always prefer it. Sometimes when it's not possible, of course, now, we are conversant with doing it even with a sitting position. But always believe me, when you're starting, the patient has to be lying down flat. Okay? And this again also helps in clipping our fundus chart. The fundus chart has to be clipped on the rigid board that rests on the patient's chest. It is oriented upside down. The 12 o'clock has to be towards the patient's feet, and the 6 o'clock has to be towards the tail. I will come to more of this when we are doing the documentation part. Okay, so this is in preparation to the viewing system, the viewing of the inside of the eye. Now, do we keep the patient in the mute mode, or do we give any instruction to the patient? Of course, we give the instructions to patients to keep your fellow eyes open. Sometimes the patients are uncooperative, so then you raise their thumb or their finger, and then you ask them to look in the different cardinal directions of gaze, or use their thumbs for fixation. Now, the important point over here is, how do we hold the lens? The condensing lens is held between the thumb and the index finger of the dominant hand, and the three fingers, the three fingers which are remaining, are placed on the patient's face to stabilize the lens and retract the lens. I have a picture also in my future slide, which I will be showing you, which will help understand this point. The
Dr.
light beam
Pooja,
has to be central.
Dr. Pooja,
Yes, sir.
can I interpret? Yeah. Uh, I practice pure retina, and still I do get a lot of patients who are having their indirect ophthalmoscopy done for the first time. So they are not aware of what you are doing. So while you're putting on the indirect ophthalmoscope, it's a good idea to tell the patient, light off, I'll be putting the light off, I'll be pushing the chair back, and I'll be examining your eyes with light. Because sometimes we don't tell them this, they're suddenly scared, light goes off, chair goes back, there's something, some metal piece in your hand, and especially younger patients, little apprehensive elderly people are not very sure what's happening. So I think it's important that if you feel that the patient has not had an internal examination before, they have no idea what they're getting into. Street lamp, they've had examination at the optician shop or elsewhere also, or the previous examination. But there are a few of our patients who have not had that before. Uh, Keeping fellow eye open is easier said than done. They do tend to shut it down over there, but it's a very good instruction to give to the patient. And making the patient follow their own thumb. They will also verbalize, I can't see my thumb. You tell them, no, no, try and look at it. And while they're doing it, you'll see things are much better. I agree with whatever else Pooja has said. Next slide, please, Pooja. Please go ahead.
Okay. So the light beam has to be central, illuminating the pupil completely. So when you wear the indirect, firstly, you have to aim those the 3 beams onto the pupil, and then you slowly slide the lens in position. After you have slid the lens in position, you have to slowly raise the lens while the pupil and the red reflex fills the lens view. Now the third point which I'm coming to is a very, very crucial point. You have to pay attention. The image system, what is the image system? The pupillary space and the fundus of the patient's eye. The condensing lens and the indirect ophthalmoscope always has to be in the same line. I have also a picture in the future slide which I'm going to explain this point. If the view goes black or appears inverted, you have moved too far away from the eye. So now this is the focal length. As I told you, the thumb and the index finger will hold the lens. The 3 fingers that you see on the first left-hand side picture are acting as fulcrum, and they will be on the patient's chin. Never leave those 3 fingers from the chin, because if you leave those 3 fingers from the chin and then the lens is in mid-air, the view will never come. Okay. So the first is focal length is correct. The second focal length, the lens is too high away from the eye, and in the third picture, the lens is almost touching the face. So then, the focal length will not be correct, and you will not be able to see a good stereoscopic view of the fundus. How do we see the fundus periphery? Examiner is at the opposite end of the meridian to be examined. To examine the 6 o'clock, the examiner has to be standing at 12 o'clock and the patient has to be gazing downward. Don't worry about this point, because when I go to documentation, I will explain properly in detail as to how you examine, what you see and where you are standing. So now examination of the posterior pole, including the disc and macula. You see that I am a left-handed person, so that the thumb and index fingers holding the biconvex lens, and the other eye helps to retract the upper lid of the patient. Okay, can you see this picture? Now, when I'm seeing the inferior retinal periphery, the patient has to be looking down. My lens is a little tilted and I am moving backwards. Okay, so that all these 3 things are in the same line. The fundus, the pupil of the patient, my lens and the indirect all has to be in tandem going back. Okay, in a rhythmic fashion. If I was to stand vertically, I would not see the image. Now see, when you see the superior periphery, the patient looks up, you are holding the lens tilted a little up so that you avoid deflections, and I am moving backward like a Bharatnatyam dancer. I'm going forwards, backwards to get a good view. So that is one more reason why there should be space behind your table so that you can move all around the patient. Okay. Now comes the
just 1 second, Pooja, 1 second.
Yes.
I think it's extremely, these last 2 slides are extremely important and the word that you use, Bharatnatyam answer, I think is very, very important. You have to be able to move your hip, your neck has to be able to bend, and it's an exercise by itself. Holding the patient's head down. I'll also sometimes push. Sometimes I'm not able to see the superior periphery, patient not looking very, very, very well. Exactly what she has done here. She has pushed the chin up a little bit. So sometimes if you don't ask the patient look up, you move the chin up a little bit also with your finger, tell the patient look up, bend your head backwards, or sometimes push the chin down a little bit. Sometimes if you're looking exactly what she's seeing now, if you see the left eye nasal periphery, you bend a little bit backwards, tilt the patient's head towards the right side a little bit. So this exact phrase that she used, Bharatanatyam dancer, is very, very appropriate over here. The whole body should move from the hip. The neck has to be moved accordingly also, and your hand should play in tandem. Of course, what is independent of your actions is the patient's eye movement, but that also you have to instruct the patient to correctly. I think this is one of the most important parts of how you can quickly do an indirect ophthalmoscopy by moving your body around too much. Instead of asking the patient to move the eye and head too much, move yourself, you'll see it faster and easier that way. And also one small point what Dr. Pooja said, darkened room. Do not keep your illumination very bright moment you start it. Keep it on the little lower side. Start moment you see patients little bit comfortable, patients coordinating with you, then maybe you can increase the illumination a little bit more. So starting with a high illumination and then reducing it when patient is uncomfortable, sometimes very counterproductive. Then you've lost the game over there. Patient will keep on moving their eyes, keep on moving their head, not looking to the light at all. Will keep blinking their eyes. Then you are watching. I will start. Then give a napkin, give clean eyes. It's a very tedious process. So when you start your endoscopy, sorry, yeah, I think we'll go ahead to Pooja after that.
Okay. So now we come to a very important technique of scleral indentation. PGs sometimes ask me, ma'am, scleral indentation is a very painful procedure. So my answer to that is that if you do the scleral indentation properly, it may cause a little bit of pressure to the patient's eye, but definitely it is not painful. And the advantage of it is a lot, because you can get a clear view of the structures in the retinal periphery, that is the ora serrata, the posterior border of the ciliary processes. It permits kinetic examination, allowing stereoscopic view. Okay, so how do we do it? The thimble is placed in the index finger. The blunt tip of the depressor is placed on the skin of the eyelid over the area of the sclera to be indented. Now, if you're examining the upper fundus periphery, the eyelid has to be first closed. The depressor tip is applied to the upper lid at the upper edge of the tarsus, so that when the patient opens the lid and looks up, the tip of the depressor slides easily under the orbital margin. Always remember that the depressor should be used tangential to the globe. Now I have a picture here. I have a small picture which will help me to explain what I was talking about. Now here I want to examine I want to indent and see the inferior retinal periphery. Okay. So now I've asked the patient to look up, exactly opposite to what you want to do. I want to examine inferior. So I've asked the patient to look up. I keep my depressor in position, okay, below the lower lid, under the tarsus, and slowly then I ask the patient to look down. And when the patient looks down, automatically the scleral depressor goes behind, glides smoothly, and I can see an indent and see the inferior retina. Okay, so an important tip over here is to look first, make the patient look in the opposite direction as to what you want to examine, and then place your depressor in position. Okay. So see the advantage of the scleral depression. This you can see in all standard textbooks. This is the picture which I've taken from Kansky. You see on the left-hand side this horseshoe-looking pigment kind of a hemorrhage kind of a thing. But when you depress, you see that the lips open up, and this is actually a horseshoe tear. You can see the dentate processes of the ora serrata, and you know that this patient is not leaving your clinic before you barrage this patient, because this is a kind of an emergency. So this is the advantage of indenting such patients. So going on to advantages of indirect ophthalmoscopy, it offers stereopsis, a large degree field of view, bright illumination, minimum peripheral view distortion, complete peripheral access with scleral indentation, and independence from the patient's refractive error or moderate media opacification. So there are a lot of advantages, and that is why when I was doing my fellowship in Shankar Nethralaya, we were absolutely forbidden to use the direct ophthalmoscope. It was criminal, actually, if I can put it that way, to be carrying the direct ophthalmoscope.
Dr. Pooja, I'll throw in a spanner over here. Is Dr. Satyajit there? Is Dr.
Yes, I'm here.
There?
Right here.
Yeah.
Right here.
So she made a very, very controversial statement regarding the use of direct ophthalmoscope. She said, but not allowed, not permitted. I have seen, I know you well, I have been to your clinic. I have seen the direct ophthalmoscope on your table. When you, and I know you see your patients separately than Dr. Pooja. So my question to you is, if Pooja enlists all the advantages, why then do you have the direct ophthalmoscope?
Well, when you have a busy practice and and you are the only surgeon over there, you are using a direct ophthalmoscope. You can see the disc and the fovea nicely. However, it is very important, and if you talk about the retina surgeons, they'll always say that the direct ophthalmoscope is something which is obsolete and should not be used. But a lot of people
I don't
use
agree with
it.
that. I agree with you. It has its place. It has its place. It has its place.
Yes.
It
So the
definitely has its place.
direct ophthalmoscope has a good 15 times magnification. It shows you a virtual and erect image, whereas the indirect ophthalmoscopy gives you only a 3 times the magnified image. But the limitation of direct ophthalmoscopy is that it has only a field of view of only 5 degrees, whereas in indirect you have almost 45 degrees of view, and you can also see the posterior pole and the periphery. Whenever I don't use a direct ophthalmoscope. I use a 90D through my slit lamp. But for each and every cataract surgery, it is absolutely not important. It's absolutely must that the fundus should be examined in detail, which is why I send all patients compulsorily to Dr. Pooja Sinha for a complete retinal examination, and then only we undertake all the different preoperative tests for cataract surgery before doing the actual cataract surgery.
I thank you so much for enlisting it so nicely. I will, Pooja, hold on here. There is a nice question from Dr. Shoigoto, which says, do we need a regular scleral indentation or only when we suspect a finding? I appreciate your question, Dr. Shoigoto. So I will answer your question from your question itself. How will you suspect a finding if you don't do scleral indentation? That's my first question. What I mean by that is, if there is a lattice very near the aura, if you will not suspect it otherwise unless you press it and see over there. So that is one part of the answer that I'm trying to give you. Second, where is the harm of doing scleral indentation? It takes a little bit more time only. Three, what Dr. Satyajit said is, if you're planning a cataract surgery, one must look for those lattices, one must look for the small atrophic holes over there, one must look for any other peripheral diseases over there. So I would say that if you've dilated the patient, if you have bothered to put on the indirect ophthalmoscope, why not scleral indent? If you tell me you need to do it every visit for a diabetic retinopathy patient, no, not necessary. If you see the patient of vitreous hemorrhage, do I press every time? Unless you're looking for a horseshoe tear, no, not necessary. So if you've done it once and you want to, you're treating a BRVO patient, a CRVO patient, old CRVO patient, you will not do the periphery, not necessary to depress. So there are conditions where I advise you not to depress also. Dr. Kapil was there yesterday before his patient disappears. Ma'am, clinically, how to identify equator? Up till now, I have never seen a vortex vein. I said this yesterday, Dr. Kapil, that yesterday's. Yeah, sorry. Pooja, go ahead.
There is a whole talk on documentation coming up later. So yeah. I think we can include your question in that talk.
Right. Just 1 second, Manisha Agarwal has written here, in the era of COVID, better not to do direct ophthalmoscope and learn the art of indirect ophthalmoscope and be away from the patient. I wholeheartedly agree with you. Direct ophthalmoscope is really going close to the patient. And I remember my boss saying, why do you want to kiss all your patients? Do the indirect ophthalmoscope, stay away from them. I agree with that. Dr. Aditya has a question, how to do in patient with lid edema. Dr. Aditya will also be showing you slides later on where you cannot do endoscopy. I agree with you wholeheartedly. Cannot do lid edema. We have come to those slides.
There are a couple of slides. Yeah. Let's finish the whole
and then I'm happy people are thinking in their mind and asking questions. That's nice. That means people are listening to the talk very nicely. Thank you so much. We'll go ahead, Dr. Pooja, please.
Okay, so my take on the take-home message here is that you do an indirect ophthalmoscopy But then you combine it with a slit lamp biomicroscopy. Okay, instead of doing a direct, you can do a slit lamp biomicroscopy, which will give you a 7.5x magnification and offer good stereopsis as well. So then, direct doesn't have too much of a role. So then now going on to a very important slide here. Why do we use commonly a 20 diopter lens? Because it offers a 45-degree field of view with the 3x magnification. The last point here is very important regarding the condensing lenses. Higher is the power of the lens, the lesser is the magnification, but bigger is the field of view. So I have a good slide here. Okay, in the center you have the 20 diopter lens, and you can see that the field of view is almost 45 degrees and the magnification is 3x. When we do ROP screening, we choose 28 diopter lenses or 30 diopter lenses. The reason for that is that we want a very big field of view, okay, which will be almost 53 degrees, but the magnification comes down. That becomes about 2x magnification. And then if the diopter decreases, the field of view decreases, but the magnification increases. Okay, so this is an important point you have to understand. This slide everyone must know. From the exam point of view, they will ask you differences between direct and indirect ophthalmoscopy. This is available in most of the textbooks, so you can go through this. Now,
I'll just make a point over here. I have never used the 14 diopter lens. I have used the 30 diopter lens for babies, ROP babies, or the people a little bit small. One can see with that the 30 diopter lens, because you can do it with little small pupils also. But I've never used a 14 diopter lens. I've never seen one also. So a lot of these things are textbooks. They ask the questions in exams. You need to know this. But this slide is extremely important. It's a very commonly asked question. Thank you, Dr. Pooja. We'll go ahead.
So properly done indirect. Now everyone can agree with me. Saves the patient's eyes, saves your practice. You can sleep well. So now we come on to the clinical relevance of indirect ophthalmoscopy. How do we chart? What are the examples of peripheral lesions? Postgraduates asked me, and we have already discussed it just 5 minutes ago. What are the indications of doing indirect ophthalmoscopy? If you ask me, try to do it in all your cases. Okay, if you have a busy OPD, select the cases where you will require more time. Call them the next day, or call them at the end of the OPD.
I think the slides have not moved ahead. We are stuck at those 3, 20, 30, and 14 diopter one on my screen at least.
What about? Can you see?
We are seeing the 14, 20, and 30 diopter slide only.
Oh, just give me 1 minute.
Mr. Manish Gupta, are you? I'd ask, yeah. Yeah, it's moved forward one slide now. Direct indirect differences. I think you've gone beyond this also.
Yes. 1 second.
We are on slide 33 of 90. Manish Gupta ji, what slide are you seeing on your screen?
It's the same slide, sir. Yeah. 33 of 90 is the same slide which I can see.
So then
the features direct
from the presentation.
And direct. Yeah.
Till we get our slides done correctly, I'll go back to the old question that Pooja left halfway through, and I also didn't let her finish at that time. Is it all the postgraduates? She said there is a blue filter of 3 filters are there. So the question she had asked is what is which filter used for? So I would like those postgraduates who have some idea Why don't you type a message, which filter is used for what, and let's see how much you all know and what you can do. She will answer the question later on. Dr. Charul is back, right? Green for RNFL, very nice. Red free can use for RNFL defects. So there's a difference over here. Green and RNFL, two different people, two different opinions. Blue filter, vessel pathology. Let us show me. Okay, what else? So let us show me what is your opinion on the red and green. Dr. Satyajit, you having dinner with your children? We can see those slides. Red freeze for microaneurysm. Nice. So green is again RNFL defect. Okay. Little different opinions here and there. Okay. I'll leave that question for Dr. Pooja to come and explain why each one is what. But thank you all for answering on that. Blue filter after to see periphery. Okay, I'll leave that over there also, Dr. Zeel. Thank you. I'll just read the names, Dr. Zeel, Dr. Sogato, Dr. Anushri, Manvi, Swami, Priyanka, Charul. Thank you so much for answering. We'll get back to Dr. Pooja answering a question later on. I want to understand if those of you who are already using the indirect ophthalmoscope, what difficulties are you having, if any? Why don't you write out your message over there, and then maybe we can use some hints that when you have the difficulty. Because I know one for sure, my fellows, when they first join us, they are little apprehensive, but they can do it in there. Usually, most of them can do it, but the indentation part of it, they're a little bit scared. And it's so I agree that that's one part which is a stumbling block. So what Dr. Pooja showed is, ask if you're depressing inferiorly, you want to see 6 o'clock place inferiorly, ask the patient to look up, put in your there very slowly. Patients feel the metal, tell them no, you won't have any pain, and ask the patient to look down. So that is one part of it. Again, you don't need to depress very hard. A gentle depression and pulling your head back a little bit, bending backward a little bit. If you're not able to see your indentation, move the depressor a little sideways, little back and forth. Sometimes
just
that
give
helps.
us 2 to 3 minutes. Just please give us 2 to 3 minutes. We're just trying to
We are
upload
going
the slide.
yes.
Yeah.
So
Just,
1 minute,
sorry.
1 minute. Anubhav here has written documentation exam is biggest challenge. Documentation. Anubhav, we're coming back to that. Anubhav. We will come to documentation. There are slides for that. Patient cooperation in skill limitation. That's exactly what I was talking about. So patient cooperation. One is don't depress very hard. It's not even though we say dynamic procedure, it's not such a dynamic thing. A gentle depression. But most important is what the slide Dr. Pooja showed, that ask the patient to look in the opposite direction. So I'll repeat myself again. If you want to depress superiorly, ask the patient to look down, put in your depressor in between the orbital rim and the lid over there. So you have enough, you're doing it far away from the lid margin. Then ask the patient to look up. You'll see a depressor slide back along with the depressor. And it by itself will show the depression. So this is one part of skill depression. Dr. Atul has written difficulty in perception of vitreous. See, if you have a clean eye, if you have an eye which has no disease pathology, it's not possible it is a vitreous, it's optically clear. Like we discussed yesterday in the class, a good healthy vitreous, you will really not see anything at all. Unless you can, it's an elderly patient, there is some posterior vitreous detachment, there are some vitreous floaters, myopic patients have vitreous floaters. In that case, what you will see, Dr. Atul, is these floaters kind of a things. In that case, you have to move your lens back and forth a little bit, or when the patient moves the eye, you will see it moving around a little bit. If you stay stationary, patient stays stationary, sometimes you might miss it. So sometimes if you are looking at, or sometimes what I ask, if I have a lot of vitreous changes, let's say a patient of vitritis, I'm just saying just for one example, and I'm not sure looking at vitritis or not, when it's very mild, I quickly see the other eye also. How clear is it? If the lenticular opacity is the same, and I'm seeing some haze over here, I know the vitreous is a little bit disturbed over here. But most importantly, if you want to, sometimes you can see the shadows of the vitreous, the condensed vitreous on the retina itself. So these are small hints that you can perceive the vitreous if there are changes in the vitreous. Um, I have not able to identify. Dr. Anubhav, here is another question nicely. Not able to identify taut posterior membrane on examination. Any tricks or tips to identify this? Now, Dr. Anubhav, I'm assuming naturally a taut posterior membrane is a posterior pole epimacular finding, and I would insist that this is done more with your 70 AD or with the 90D or even the direct ophthalmoscope. I have no issues with that. So this is more better appreciated with that. I don't use the direct ophthalmoscope. I would insist that the 70 diopter is a very good lens to use it to see the TPHM very carefully. The indirect is not a good instrument to look for the TPHM at all. And again, tricks or tips, compare with the other fovea, look at the blood vessels at the fovea, what we discussed yesterday, foveal vascular zone, the size of it, that area over there, see if there's small wrinkling of vessels over there, see if there any shiny reflex over there, see any shiny reflex over there, and in those points, you can make out a taut posterior highlight membrane. I hope I've been able to explain myself. Yes, sir, but even on 78D, how to identify, right? So he's following the question on that, right? So if you're looking at the 78D, you will see a shiny reflex. If it's a minimal membrane, if it's a thick membrane, and it's very obvious, you can see there's a gliotic white sheet over there. Glasses again is the word I'm using. You will see the whitening over there. You will see the vessels over there. If you notice, they are a little bit wrinkled over there. The larger if it's a thick, large membrane, how can I? If you think it's a large membrane, the vessels will be pulled towards the fovea. These are hints that there is a myostrat membrane over there. And I would say in today's day, at the top of a hat, most of us would do an OCT if you have even the slightest doubt of the fovea not being clear. And you compare the other eye, you see both eyes are a little different. We are back to slides. Yeah, we are back to the slides. Dr. Unity Fahan has written, how can I ask question? Exactly where you've typed, how you can ask question. Write your question there itself, Dr. Fahan. I think that's how you can ask a question over there. Thank you, Dr. Anubhav. Thank you for thanking me. Are we back to the slides, Dr. Pooja? Then fine. Mr. Manish Gupta, I would request you to coordinate with Dr. The slides did come back in the middle.
Yes, sir, it's available. No, I think it's again gone, sir.
Yeah. Just please on the phone coordinate with them. Well, it came back in between.
Yeah, it is yes.
No, this is one question going away. Shoigoto, can we differentiate subretinal heme and sub-RP heme by red free light? Yes, but the point remains how thick the heme is, how old the heme is. Sometimes very difficult. And we normally say darker and brighter. The more deeper it is, the more darker it will be. More anterior it is, the more reddish it will be. Kapil's question is, Dr. Kapil, sir, any trick to identify ora serrata and vortex veins? She will be showing slides of that. But Kapil, I'm assuming you are very well conversant if you ask me for that ora serrata. I always tell those of my fellows or PGs who tell me I've never seen the ora serrata sir properly. I'm not very sure. I would request you that catch hold of a patient with aphakic. I don't know, aphakic patients are very difficult to come by nowadays, but get rid of an aphakic patient or a good pseudophakia, which is a very well dilated pupil patient. And in those patients, ask the patient to look far very. Yes, Satyat. And you will then see the aura over there. All Mr. Manish, just wondering what's happening over there.
We are coordinating, sir. Giving a call. The slide just came in and again.
Yeah. So, ora serrata again on indirect ophthalmoscopy, the depression over there has to be very anteriorly. That means
Pooja, can you hear
Yeah,
me?
the slides are back.
Yeah, can you see the slides?
Yes, yes, Pooja, they're fine, they're fine.
I'm extremely sorry for this delay.
Let's go ahead, let's go ahead.
Yeah. Okay, so now have we already discussed that preferably all cases need indirect ophthalmoscopy, but when we split it,
Dr. Pooja, one second. We'll just answer two more questions. We'll come back to them. These questions keep moving up on the meeting chat box. Dr. Unity Fahan has written trick in seeing. The question that person has written is trick in seeing snow banking in snowballs, sir, please. So Pooja, you have to answer this question. When you are doing indirect endoscopy, how to look for snow banking and snowballs is the question. Uh, and Dr. Atul's question is slit lamp biomicroscopy regarding slit size and angulation in matrix. Dr. Atul, I I will leave your question for now. I'm sorry for that. We'll stick to this indirect thermoscopy right now. But Pooja, you will have to answer the question later on. Snow banking.
yes.
Please go ahead,
So the
Pooja.
snow banking, so there comes the importance of doing scleral indentation, because if you don't do scleral indentation, snow banking is sometimes a feature that can be missed. So
Absolutely.
when you're suspecting that the patient has features of uveitis, and we all know snow banking is a feature of intermediate uveitis, you always have to do a scleral depression, and there you can see this curdy kind of a band-like formation overlapping the ora serrata and posteriorly, and that is the pathognomic feature of snow banking. Okay, and snowball opacities, you can see them like as the name suggests, small balls of opacity in the inferior vitreous, and once you see it, you will not miss it. Anything more, sir, you want to add to this?
No, absolutely fine. We'll go to the talk. We'll go to the talk.
Okay, so now based on history, when a patient is complaining of flashes and floaters, it will be absolutely criminal if you don't do an indirect ophthalmoscopy, because what will you see, PGs? You have to rule out horseshoe tears, retinal holes, an RD, and because these could be preceding signs for this problem. So flashes and floaters, a sudden loss of vision, we have to rule out retinal detachment, anything in the vitreous like a vitreous hemorrhage, anything behind like anything involving the macula, sudden loss of vision may cause these lesions may cause sudden loss of vision. So you have to do an indirect ophthalmoscopy. If the patient has a history of blunt trauma, what do you want to see? You want to see if there is any kind of vitreous hemorrhage, or if there is any kind of a choroidal detachment by doing a peripheral examination. If a patient is wearing high myopic correction, of course, retinal holes. If the patient is diabetic or hypertensive, of course, there are findings in the posterior pole, but you must also see the peripheral retina in those cases. Based on diffraction and slit lamp examination, high myopes, again, iris tears, you have to look for corresponding signs of trauma inside the eye, or a hypopyon after cataract surgery. You have to rule out any kind of vitritis and other features of endophthalmitis in the posterior segment. Low intraocular pressure. When the patient has low intraocular pressure, what features you will see on the retina? You will see choroidal detachment. Okay, so that will be missed if you don't do it indirect. So Tobacco-Duston SLE, capillary hemangiomas on the face. You look for other retinal hemangiomas and facial abnormalities. What are the pathological indications? Any kind of a retinal disorder, intermediate or posterior uveitis, as someone rightly asked, snow banking, optic nerve disorders, and intraocular tumors. It could be at any level. It could be on the optic nerve. It could be in the retina, choroid. Okay, so these are the pathological indications. Now, this is a very important point. If you have to announce that the patient is perception of light negative, it is imperative that you have to make the room darkened. Switch on the direct the bright light of the indirect ophthalmoscope. Close the fellow eye and check properly once, twice, thrice before declaring that this patient is PL minus. Okay, and then before LASIK and in any other intraocular surgery, you have to rule out lattices and other peripheral lesions. Pre and peroperatively, there's a suspected cortical or a nucleus drop. If there's a suspected perforation and squint and buccal surgeries, If there's a suspected perforation after periocular block, you have to look for suprachoroidal hemorrhage, you have to look for retinal detachments, okay? Or if there is a retrobulbar hemorrhage. Now comes a very, very important point of documentation, okay? And that is why I told you that when the patient is lying down supine, the fundus chart has to be clipped on the rigid board that rests on the patient's chest. Firstly, you have to be prepared with the fundus chart, okay? The fundus chart has to be oriented upside down. The 12 o'clock has to be facing the patient's feet, and the 6 o'clock has to be facing the patient's chin. What I do is, when I have the chart in my hand and the 12 o'clock is facing superiorly and the 6 o'clock is inferiorly, like I have the proper chart in my hand, I first document the optic nerve and the macula. I will show you in pictures also, but first I make sure that, okay, this is the right eye and this is the left eye. So first I document my foveal reflex and the optic nerve head, and then I keep the chart on the patient's chest in the manner that I have told you, 12 o'clock on the patient's feet and 6 o'clock towards the chin. Now, this is a very important point that you have to note. We always see the area of the fundus we are actually looking at, but the image of the lesion is reversed. Okay. So, for example, if you are seeing the right eye of the patient and you're looking at the superior-temporal quadrant, okay, somewhere between 10 to 11 o'clock or 12 o'clock, you are actually, and you see lesion there, the lesion is actually there. The lesion is actually in the superior-temporal quadrant. PGs have a doubt. Sometimes in the beginning, we also had a doubt, okay, we are seeing the lesion in the superior temporal quadrant, but actually it is in the inferior nasal quadrant. It's not like that. You have to make it very simple. Wherever you are seeing the lesion, it is actually right there, and then, okay? It is actually right there. So if it is the right eye, superior temporal quadrant, the lesion is in the superior temporal quadrant. If it is the left eye, 6 o'clock position, the lesion is actually in the 6 o'clock position. Only, what is the difference? You are seeing that it is upside down and it is laterally reversed. Okay. And but what you have to do is, wherever you are seeing the lesion, whichever quadrant you are seeing and focusing, you have to be standing diametrically opposite that quadrant. So if you are examining the 6 o'clock inferior periphery of the left eye, you have to be standing at the head of the patient at the 12 o'clock position, diametrically opposite. This is what you have to remember. But the lesion is actually in the same quadrant as to where you are looking. So this is what I have already told. We should be standing 180 degrees away from the area we are seeing. Posterior refers to the central and the anterior refers to the peripheral. Is this point very clear? The examiner records the inverted image that is seen. Now, this is again controversial. Many people say that we start with the peripheral examination first and then we move on to the center. But at Shankar Nitale, we have been taught to first document the findings in the macula. Why? There are some advantages which I feel it is easier to draw thick caliber vessels when they are arising from the optic nerve. Okay. And that is easier to draw, and then you branch out in the periphery, because the opposite would be a little difficult. So that is my view. Dr. Saurabh, what do you suggest?
No,
What do you recommend?
it's not the question of Shankarita, I totally agree with you. This is how it should be done, because you have to see the posterior pole first. That's easiest to see. So study your posterior pole, draw your disc, draw your macula, follow the vessels away from the disc into each quadrant, into each clock hour, and that's how it has to be done. And I think exactly what you said, I totally agree with you. That's how it has to be done. You cannot be seeing periphery once, coming back posterior pole, again seeing. I do agree, when I was a postgraduate in my third year, because, and I say this with a lot of humility, most of my teachers were not doing indirect ophthalmoscopy, because I'm talking about nearly 30 years ago, at that 25, 30 years ago. So I would keep a direct ophthalmoscope, see the fundus of the direct ophthalmoscope, put it down, put on the indirect, and keeping the patient lined up with the chart over there, I would start drawing again. So I
Okay,
agree
so
that
this tip is
sometimes,
a very useful tip, and I'm sure you will not get it in textbooks. So this is the advantage of.
because I just couldn't figure out what the hell was happening. And then I remember when I joined, when I joined for my fellow, when I joined as a Retina fellow, and where Indirect was compulsory, I remember I was told that exactly what Dr. Pooja said. If you're looking at the right eye, supertemporally, and you're still confused the horseshoe tear there or not, in your mind, imagine that you're standing in that quadrant. Uh, Again, there is a question here by Dr. Anubhav Hire. Correct position to stand to examine the supratemporal retina. Diametrically opposite would be inaccessible. I do not agree with you. Why not? On any chair, in any proper position of the endoscopy, where the patient lies, where the patient sits, on the chair that you have, you should be able to go around all the sides. There is no question of inaccessibility. If it is inaccessible, you cannot examine that area. Uh, if it is a couch, which what we have mostly, what we have nowadays in our OPDs is a patient sits on the couch, the sit up in front, then you move the sit up away, patient goes lies down backward, or you have an examination table and you will go all around it. So there is no question of diametric opposite will be inaccessible, it will be accessible. So if you are seeing supratemporally of the right eye, you are standing on the left side of the patient, little on the lower part, near the patient's left shoulder. I repeat myself again, if you want to examine the right eye supratemporally, you should stand on the left side of the patient, little bit near the shoulder, with the patient looking up supratemporally out in the right eye outwards, upwards, and you standing right opposite side over there. Conversely, if you're looking at the left eye lock, exactly what example Dr. Pooja gave, you should be standing behind the patient's head and exactly ask the patient to look down at their feet. That's the only way you will see the periphery. Dr. Pooja, we'll go ahead, please.
Yes, sir. And then the area from the disc to the equator is drawn quadrant by quadrant, following the retinal vessels, other fundus features, limits of the RD, etc. Okay, so this is another good chart that is available, and this is how you clip the patient on the patient's chest, and this is how you are going to draw. Now, this is how the Amsler chart, this fundus chart looks like. What is the full name of this chart? Can anyone tell me?
Amsler-Dubios chart. Amsler-Dubios
Yes,
chart.
this is the Amsler-Dubios chart, DUBOIS chart, and it has 3 circles. You can see 3 circles here. So the innermost circle it corresponds to the equator. The middle circle corresponds to the ora serrata, and the outermost circle is the junction between the pars plicata and the pars plana. So when you are drawing on the fundus chart, you have to draw the ora serrata first with black curved lines nasally, because you know that the dentate processes are more prominent nasally. So those curved lines come on in the nasal side, and then basically follows the contour of the ora on the left hand side. So how do we document the foveal reflex and the optic nerve head? This is an important point. Sometimes external examiners may ask you. So foveal reflex is in the middle of the chart. Okay, you make a small dot there, and the optic nerve head of the right eye will be somewhere between 1 and 5 o'clock. Okay, just 2 disc diameters away from the foveal reflex. So that will be on the right hand side, and because we all know that the optic nerve head has to be drawn nasally. And in the left hand side, it will be on the left hand. In the left eye, it will be on the left hand side. The foveal reflex will be in the center, and the optic nerve head will be between the 7 and the 11 o'clock. Okay, so these are the 3 lines. The fundus drawing is made in starting with the optic disc, and then you draw the retinal vessels, and then you can branch them out and reach up till the ora serrata. So any questions anyone wants to ask on this? Sir, are there any questions?
Dr. Pooja, I have a statement to make over here. I recently he's a senior retina fellow with me right now working with us. And I kept asking him, bugging him, why are you not doing big drawings? Why are you not charting out these patients' retinal detachment? And he said, sir, why I can take a fundus photograph. So my question to postgraduates is, on what, it's got a specific name to it. What fundus photograph can you take that you can see nearly till the ora? I will not say ora, nearly till the ora. What machine or what is the name of this? If you can post over there. We'll go ahead, Pooja.
Okay, sir. So now comes color coding. Okay, once you have all the fundus chart in position, you know how to do the indirect. You're seeing the lesions very well. How do we color code them? So there is a confusing array of colors. We all know it is important from the theoretical point of view. You have to learn it up, but there are certain important colors and tips that I would like to mention over here. Okay, so first we just go on to this slide. Black color coding is for the retinal or choroidal hyperpigmentation, a buckle in the attached retina. Brown, anything in the choroid is brown, okay? A choroidal detachment, pigment, melanoma, choroidal rupture, buckle in the detached retina is all color-coded brown. Blue, we all know, an off retina, that is retinal detachment, a subretinal fluid, retinal thickening, the ora serrata, it could be black or it could be blue, lattice degeneration, okay? Or retinoschisis, veins, they are all color-coded blue. Then what is red? Red is attached retina, pre-retinal and retinal hemorrhages, microaneurysms, macroaneurysms, and arteries. What is orange? Any elevated neovascularization is orange. Purple is a flat neovascularization. Anything in the vitreous cavity is green. This is the common funda you have to learn. Anything in the vitreous cavity, it could be a vitreous hemorrhage, a CNVM, it could be cotton wool spots, fibrous proliferation, any media opacities, IOFBs, everything is color-coded green. Yellow could be hard exudates, subretinal hemorrhage, or active chorioretinitis. So this is the fundus drawing. I've told you have to chart the foveal reflex and the optic nerve head.
Pooja, I'll just stop you for a second here.
Yes, sir.
Those of you who attended yesterday's class, we said the size of the optic nerve head is how much? Can you type the answer over there? The size of the optic nerve head. And what is the macula size also? I want the answers to both of them to know. Somebody has already written yes. Great. Arushri, Nisha, Samiksha, Priyanka. Excellent. So we are very, I am so happy. People have mentioned everything. And 5.5 millimeters. Excellent. So all of yesterday's class, I agree with all of you. Same to people, Manvi, Samiksha, Kapil. Thank you so much. I'm so thrilled. It's really wonderful that I get these answers so promptly. So at least a few of you are clued on what we are saying. Pooja, you're doing a good class. We have good people listening to all of us. And I will also thank Dr. Anubhav and Dr. Samiksha. They actually wrote Optos over there also. So I wrote their names down. Both of them wrote the Optos machine is one machine which helps you. So, my fellow told me, sir, kya India mein karna hai? Optos machine बैठा दो peripheral तक दिख जाएगा. But all these machines, and I also saw recently the Zeiss machine, the name being, I forget the name, and we had a presentation by Dr. Anshuman Sinha from Ranchi. He has one of these fancy machines in Eastern India. I think he's one of the only people who has this machine, and he can see way to the periphery. Claris 500, Ashish Majumdar, correct, the Claris 500. Yeah, and thank you, Ashish, so much. Dr. Ashish Majumdar has written Claris over there, and you can see way to the periphery. So life is getting easier, life is getting better, but all of us at all times will not be exposed to these machines, and you have to learn your basics first. And like somebody said at the beginning, what is the indication to depress? The indications are always there. The more you depress, the more findings you'll have, the more confident you are, the more confident you tell your patient everything is okay. So I agree. It'd be love to have the Claris the Optos with all of us, but till we get that, let's all do it and depress properly. Pooja, please go ahead.
Yes, sir. So then this is the fundus drawing. We all know. I've already explained all this, so I can just go on fast. The horseshoe tear or any tear, you have to make a red color in the to fill up the tear or the hole, and followed up with a blue outline. Retinal hole with operculum is again red, and the operculum, since it's in the vitreous cavity, it has to be color coded green. This is white without pressure, blue hatch lines. Lattice, commonly you will be asked to draw. It's a blue, color-coded blue with blue hatchings, okay, crisscross hatchings in between, inside. And then sometimes they have atrophic holes, so then you draw these small red dots in the center of the lattice. This is again the inner and the outer layer breaks. Inner layer breaks are blue with blue hatchings, and the outer layer breaks have a red center with a blue outline. So retinal RD with the PVR, you see these star folds. The subretinal gliotic bands have to be drawn yellow. Okay.
Pooja, I think slide has got stuck. Yeah. Please go ahead.
Is it all right, sir? Yeah.
Yes.
So this is the total RD. These are hemorrhages again at the different levels. You have to draw dot and blot hemorrhages in red. You have to draw subretinal hemorrhage in yellow. Vitreous hemorrhage in the vitreous cavity again, it has to be drawn green. and a subhyaloid hemorrhage could be orange or red. Choroidal melanoma, again brown, no confusion for that. Choroidal rupture, again yellow. Diabetic retinopathy, this is a very colorful
just stop. Just 1 second, Pooja.
Yes, sir.
I once had a fellow who came to me, sir, why do you all make things so difficult? Why can't you all keep the colors easy? And then somebody, the other fellow said, most of what you see, what colors they are, put in the same color. So hard exudates, soft exudates, put as yellow. If they look yellow, put it as yellow. Hemorrhages, whether it's daughter-in-law, it's flame shaped, whatever it is, put as red. So there's no mugging up over there. Anything in the vitreous cavity, which means exactly what Dr. Pooja has shown over there, tractional detachment, that's a fibroscopal proliferation, a vitreous hemorrhage, what she showed before, or the operculum, anything in the vitreous cavity, put it as a green. I'm giving a very simplification to what she has shown, what she's showing over here. Any retinal pathology, that means a retinal detachment, a retinal thickening, what she has shown here, cystoid macular edema, all as blue. I'm making it very simple for you. But there is no shortcut to what she has just shown. Please don't mistake me. What she has shown is what you should know. But if you can't still remember, at least remember this much, that anything vitreous cavity is green, any retinal pathology is blue, the hard exudates, you see them as they are, the NVEs, the retinal hemorrhages are all as red. If you can't remember the things, anything below, anything with the choroidal level is brown. A choroidal detachment, a choroidal melanoma is brown. You can just remember these basic things also. I think will be enough for us also. But this is not a reason not to know all of them directly or correctly. So sorry, Pooja, please go ahead.
Yes, sir. And then this is an amalgamation of all the different colors. That is why the diabetic retinopathy pictures look so colorful. So you have a CSME, which is color-coded blue. You have hard exudates as yellow. You have new vessels as red. You have a fibrous proliferation as green. So everything comes together in one picture. And then you have this choroiditis, which is an active choroiditis, and this is yellow. And exactly you see yellow and you draw yellow. Again, choroidal neovascular membrane. These are the different colors. We all know this is all a repetition. Now, the indirect ophthalmoscopy is not always a bed of roses. It has its difficulties. It has its indications when it becomes difficult. And my disclaimer here is that these beautiful slides which I'm going to be presenting now are actually Dr. Saurav Sinha's slides, which we had presented together in, I think, the DOS meeting and the AIOS meeting. We did a indirect ophthalmoscopy course together. So these are his slides, and I'm just taking the liberty of going through them. So the difficulties here are categorized as a poor doctor, a poor patient, poor instrumentation, and clinical situations. Okay. So now coming on to a poor doctor. By a poor doctor, we don't mean a doctor who doesn't have any money. Okay. A poor doctor means a doctor who is not well trained or a very conversant doctor. A doctor who has so many patients that you lack patience, you lack motivation. There is just no time. People are just waiting in the queue, wanting to see you. There is not enough time to do an indirect ophthalmoscopy, a scleral indentation, and so on and so forth. So this is a category of a poor doctor. Now, what is a poor patient? You see on this picture on the right-hand side, a small boy, a baby, lying very nicely in a cooperative fashion, and the doctor in a very nice way is pouring over him and seeing in the fundus. Okay, so is this situation in the real life? No, not always, not many a times, because the patient will be screaming, the child will be screaming, waving his arms in the air. The doctor will be all sweating, perspiring. So, and especially children, uncooperative patients, children, very elderly patients, they are hard of hearing. They will not know whether you're saying niche dekho, upar dekho. Apprehensive patients, mentally challenged patients are patients where indirect ophthalmoscopy becomes very difficult. Poor instrumentation, misaligned indirect, scratched lenses. Okay, many a times we are not able to make out, अरे ये दिखता नहीं है, fundus नहीं दिख रहा है, but we don't know and we are not aware that the indirect has a thin film of dust on it. The condensing lens has a thin film of dust on it. It is a scratched lens, and that is why that is all accounting to a poor view of the retina. So instrument also has to be kept in mind that your instrument is in perfect health and condition, and poor illumination. Clinical situations, as one of the postgraduates was mentioning, orbital and lid disorders, conjunctival conditions, poor pupillary dilatation, media opacities, post-trauma, post-cataract surgery. These are certain clinical situations where it is difficult. So going on to the orbital and lid disorders, you were saying something, sir?
We mentioned that yesterday. Somebody had asked that question because your previous slide said cataract surgery. So we had defined yesterday that at least a month we waited. It's a very poorly done cataract surgery with some sutures put over there. So not to depress before a month. That's what we discussed yesterday. So I think with the continuation of that, that's fine by yesterday itself. Please go ahead.
Yes, so the orbital and lid disorders, any prominent orbital or bones or very deep set eyes, it is very difficult. As you must have noticed, it is very difficult to do cataract surgeries in such eyes. And similarly, indirect ophthalmoscopy also becomes very difficult if it's a deep set eye. Very small palpable fissures, again, the technique becomes difficult. Now, so look at these pictures on the right hand side. A totally chemosed eye, symblepharon. It is very difficult to do indirect ophthalmoscopy. Sometimes the pupil just doesn't dilate. It could be an elderly diabetic, pilocarponized eyes, posterior synec, pupil is small, you are barely able to see the posterior pole, let alone the retinal periphery. Any media opacities like a corneal pathology, an anterior chamber reaction, sometimes post-trauma there's hyphemia, there is a PCO following cataract surgery, there's a lenticular opacity, grade 3, grade 4 cataracts, vitreous hemorrhage, vitreous haze, indirect ophthalmoscopy becomes very difficult. Post-cataract surgery, when there's a small rhexis, PCO, IOL edge effect, sometimes when we are doing indirect lasers, also sometimes the IOL edge effect causes a lot of these glare effects, and indirect ophthalmoscopy and lasers become very difficult to perform. And sometimes then there is poor dilatation and post-surgery. So then again, this is a revision of my previous slide. Advantages of indirect over direct, stereoscopic view, larger field of view, we cannot depress in these patients. Now, this is the answer to one of the questions which the PGs were asking. When do we not depress? We do not depress post PK or RK surgery, especially if it's a very recent surgery, less than 1 month. Presence of any bleb. Okay, you depress nicely when there is a bleb, and then you get a call from the glaucoma consultant screaming at you and telling you, what have you done to my bleb? It's all become flat. Presence of rubeosis, hyphema, you don't want to depress and increase the bleeding further. Proliferative retinopathy, sometimes the vessels are very friable, and if you keep depressing, there may be episodes of hemorrhage. Suspected glow perforation, post-trauma, post-periocular injections, very recent periocular injections, and the early post-operative period less than 1 month, it is not advisable to depress. Now, just two slides.
Just quick. Sorry. Can we go back to the previous slide? This is important. The previous slide, please.
Before this? Okay.
Yeah.
Even before this?
Go slow. No. Where not to depress. Yeah. I have a question here to all the postgraduates. In a patient of CNVM and proliferative retinopathy, let's say PDR specifically, why not to depress? Bleb will get ruptured. Post PK, the PK can open up. The RK old time RK surgery that can open up. So these are hints I'm trying to give you a post trauma. So why in a case of PVR or why in case of a CNVM, why would one want not to depress? If you all can if you all can answer over there, we'll go ahead, Pooja.
Yes. Vessels are very fragile.
Yeah, no. Please answer on the message, Shagota. Thank you so much. Yeah, but
okay, so just
no. I would request not to, if anybody not to speak up, please put your answers on the chat box. Yeah, go ahead, Pooja.
Okay, so just 2 slides on the laser indirect ophthalmoscopy. Since we already know the procedure of doing the indirect, and we are very now conversant with it, what are the indications for LIO? It is ideal for patients best examined in the supine position, like neonates, small children, disabled patients with physical and mental handicap. That is when you want to laser them in the lying down position with the indirect ophthalmoscope. When you are doing pneumatic retinopexy, a proliferative diabetic retinopathy with vitreous hemorrhage, because you can barely see the retina. Okay, you can see strands of hemorrhage, and then you see the retina, and then you see the hemorrhage again. So when you are doing an LIO, it's always better to laser such patients, and easier also in these conditions. Any vein occlusions or vasculopathies like Eales disease, peripheral laser photocoagulation beyond the arcades in PDR, or barrage around the HST, or a peripheral tears close to the ora serrata, your work becomes much easier if you have the LIO in hand. Laser around lattice degenerations in myopes, peripheral retinal hemangioma, ablation of peripheral avascular retina in ROP, a laser in Coats disease, because we all know these are peripheral diseases, and treatment of retinal tears immediately after buckling procedures of the sclera. So now I'll just end my talk here with just a couple of nice pictures, which you can see only when you're doing an indirect ophthalmoscopy. See this fresh RD, you see this bullous retina floating up in the vitreous cavity, and the peripheral view is very best appreciated if you do an indirect ophthalmoscopy. These benign degenerations are absolutely, you will miss them if you don't do an indirect ophthalmoscopy, because they're all peripheral. Okay, these different degenerations that you have. This is a picture of a lattice degeneration. You see this black patch with these hatch lines. So this is a lattice. It's a peripheral retinal view, and only when you do an indirect you will see it. Breaks in the lattices, snail tag degenerations, and acquired retinoschisis. This is a retinal hole with a freshly lasered mark. All the fresh laser marks also have to be coded yellow as you see them. So this is again a peripheral retinal hole. Snow banking, as someone was asking me, with these cotton ball opacities, these inner and outer retinal holes, endophytic retinoblastoma. Sometimes you have peripheral tumors. And stage 2 ROP, stage 1 ROP, when you see the demarcation line, when you have to see the new vessels, the proliferative ridge. Okay, that only is possible if you do if you examine the peripheral retina. So thank you for your kind attention. One more point I would like to make to all the postgraduates is, when you want to start doing indirect ophthalmoscopy, choose the easy patients first. What I mean by easy patients is patients with high myopia, good, nicely dilated pupils, clear media opacities, cooperative patients, educated patients. These are the patients where you should start your indirect ophthalmoscopy, preferably. If you choose the patients where I've shown difficulties in doing indirect ophthalmoscopy, like small pupils, hard cataracts, then you will get little, upset, because you'll not be able to see what you really want to see. So thank you for your kind attention, and I'll be happy if I can answer some more questions. Over to you, sir.
Yeah, I'll just acknowledge Dr. Kapil, Dr. Priyanka, Dr. Manvi, Dr. Swami for giving correct answers to why we shouldn't